initially you're going to look for that STEMI, that ST segment elevation. You don't see it. What we're saying is you're not done.
Because change to us for survival means danger.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Well, we just got back from Boston.
Back when the earth was young.
Yeah, that one.
We all had to have our things, we say.
Yes, little, ticks or quirks or isms.
Nervous ticks.
Isms, yeah. But yeah, we just got back from Boston. You spoke at a conference. It was a great conference.
It was a really good conference.
Met some great people.
Really cool, fun, excited, passionate people about EMS.
Yeah, for sure.
Brad Newberry and his staff.
Chief Reardon from Duxbury.
Some of those Harvard professors, really at the tip of the spear with
disaster management.
Yeah, it was really cool.
Good stuff, Talked about death notification stuff, mental health for first responders, just a lot of good talks.
Right.
But your talk was on a topic that we've discussed on the podcast, and it is becoming more and more a hot topic, I think, in EMS.
It is.
Yeah.
It's interesting to see people. I had people raise their hand if they were familiar with something, or most of the people raised their hand. Right? But then there was some of the stuff that we talked about, and only one person raised their hand. There were a couple hundred people there.
Yeah.
And it was, we had a similar experience on the East Coast at a different area. I don't want to say who it was, but no one knew what we were talking about. And so some of the stuff is kind of cutting edge, and some of the stuff we're looking at just came out this month.
Yeah, April of 2025 for context. Yeah.
And a lot of what I was...
April 1st, as this is not an April Fool's Day joke.
No, that's right. April
this
1st.
Is real. That's right.
Yeah, it came out this month. So that's this is really kind of cutting edge, kind of tip of the spear kind of stuff. And the scary thing is that if you're not aware of these things, you could be missing, even more than I thought.
25 to 34%.
I said 25%, right?
Well, that's what most of the data has said. I think this one actually goes up to 34.
34. I think it said 25 to 34%. If you're
25,
if you're only looking for the STEMI pattern, you're going to miss 25 to 34% of occlusive lesions. So what does that mean? We're so stuck in the STEMI paradigm that sometimes we even forget what that means, occlusive MI.
Right.
And that's so. The STEMI is a pattern we look for to flag us. Wow, this patient needs to be reperfused because they have blockage of their coronary artery. If you don't get it reperfused emergently in the cath lab, then you're going to lose heart cells. And the whole adage of time is heart, right? So the problem is that if you're only looking for the STEMI flag, you're going to miss 25 to 34% of heart attacks, occlusive MIs in your community. So if you're listening to this and you're not looking for these patterns, you could be missing 1/3 of all of the heart attacks.
Right.
Of all the people that need emergent catheterization, you're missing. It could be even more than 1/3 of them. That is, to me, that's why this is so mind-blowing. And that's why we had so many people
coming
after the conference wanting more information. And professors coming up to us and saying, I'm not teaching this, I need these. And I've lost count of the number of people who've contacted me wanting the slides. So this is pretty cool stuff.
It is. And we did, like I said, we did a podcast on this last year, 6 months or so ago, 8 months or so. And that was the data at that time, but it has evolved. We're learning more. And, that's one of the things that, as a physician, you guys are very scientifically minded, and you realize that data evolves and changes the way that we practice. And as EMS providers, we need to think that way as well. Whether we're fire-based EMS or private EMS, doesn't matter.
Right.
If you're an EMS provider, you need to understand that just because that's how you learned it in school 5, 10, 15, or 20 years ago, it's totally different now. Things change, and I know that's a very difficult thing to do in the fire service. They don't like change. Well, that's not what I was taught 20 years ago, and it's like, okay, but I mean, it's no different than fire tactics. Like, we change, and sometimes the change is good. Sometimes we realize after doing it for a while, like, this didn't really make an impact or wasn't really good. But this is data that we need to at least be paying attention to.
And I'm so glad you brought that up. And we talked about this in Boston. Is unfortunately with change, our brain is so wired against change.
That's right.
Is that we will actually be presented with a new and innovative idea that is clearly better, and we will still resist it, just because it's change, even though it's better. Yeah. And those paradigm shifts aren't uncommon. We talked about Copernicus going from a geocentric solar system, which is not true, to a heliocentric solar system. I mean, there are people out there that still believe in a flat Earth. You know, it's like it's ridiculous.
Driving to Denton, Texas, there's a guy that drives around in his car. He's got flat Earth and all this stuff all over his car. Oh yeah, he'll go down to the square and.
No, that's absolutely ridiculous. We know that's to be not true.
Well, the pictures are false, Eric.
The
pictures that you see all over the internet are false.
You know, thousands of years ago, the Hellenistic, the Greeks were the
we're getting
first
off.
ones
We're getting way
that
off.
actually saw the spherical. It's silly. Anyway, but even that though, in defense of the flat earthers, I mean, the change is tough.
That's how our minds resist it.
And it's the amygdala.
Right.
It's that part of the brain, both sides of the brain actually, connected to the hippocampus, that it resists change, because change to us for survival means danger. We get into a system,
we want to be
something's
comfortable.
different.
Ooh,
red flag.
Yeah.
You know, you get home and somebody's been in your wife's jewelry box. It's like, ooh, somebody been in my house? Danger, right? Well, the same thing's happening with the paradigm shift from STEMIs. Right now, we're comfortable with the STEMIs, and a lot of advancements have come from the STEMI paradigm. I mean, we've gone from Q-wave 30 years ago to STEMI today, and we have now created this ER pathway from the pre-hospital environment to the cath lab, where we have expedited people's reperfusions, and we're getting people into the cath lab in minutes.
And that's why it's important. You know, I have this conversation a lot of times with people like, why do we need to know all this stuff? Like, you know, just take them to the hospital. And it's having a dramatic impact on patient outcomes. You know, dramatic impacts on that. The earlier we can identify potential patterns. Now, I always say this when I'm teaching STEMI stuff, and I'm not a great, I mean, I can read 12 leads proficiently. You know, I can catch, I look at it from the lens of, what do I need to catch as a pre-hospital provider? We were talking about this before. Like Dr. Yu, that...
Our electrophysiologist we interviewed,
the genius guy. Like
Dr. Guerra, all these guys.
That's all they do all day, right? That's all they study. That's all they do is EKG patterns and all these different... Like, there's no way as a paramedic or even an ER physician that you're going to be an expert in all these things, right? So we're not suggesting that you need to go out and, I mean, if that's your thing, if you get, you know, enjoy studying these things, go for it. More power to you, have at it. These OMI criteria are very complicated and they're evolving, right? You certainly need to be familiar with the fact that there are some criterias out there. And we're going to talk about some AI assistance, and you'll give some data on that that's pretty interesting. But I guess my point is that when I'm teaching EKG, STEMI stuff, my job as a paramedic is not to say 100% that this patient's having a heart attack, right? Or that they have, you know, an occlusion somewhere. My job is to look for patterns that they could be and then forward that along to you in the ER. And then you look at it with your years and years of schooling. You make a decision, and then you probably pass it on to a Dr. Guerra or somebody like that, and then they make the final decision on what they're going to do, right? But early identification is huge with these patients.
Yeah, so this is a screening tool. The EKG is a screening tool.
Exactly.
You should be getting EKGs that are not STEMIs. You should be getting EKGs that are not signs of occlusive MI.
Right.
The goal is to capture everyone that's having one, knowing that you're going to capture some that didn't have it at the beginning.
Right.
Those are called false positives.
Right.
And that's what we're supposed to have.
Yeah.
And we're supposed to even do screening on people who don't have any occlusive disease at all.
Right.
So those would be a true positive, a true negative, right?
Yeah.
What we do not want to have are those false negatives.
Right.
That's a screening tool is poor if you have false negatives.
Right.
That's kind of the goal here.
Yeah.
And that's the problem with the STEMI paradigm, is that right now you're getting an EKG on someone, and you're reading the EKG, and you're looking for a STEMI. And if it doesn't show STEMI, then it's immediately brought into the bucket of a non-STEMI.
Yep.
Right.
And then it's kind of dismissed. I mean, I know in my experience with the doctors, I remember one case in particular, guy having crushing chest pain, diaphoretic, had multiple MIs in the past. I think I've told this story before. Get to the ER, he's no elevation, but I'm basing it off my patient presentation.
Right.
And the ER doctor looks at the EKG, this isn't a STEMI, literally throws the 12 lead down and walks out of the room.
And that's short-sighted and foolish.
Yeah.
But let me explain something about the ER perspective.
Okay.
So in the ER, when you bring in a patient that's a cardiac patient with an EKG, scary or not, right? If it's not a STEMI in the ER, it doesn't go emergently to the cath lab.
Right.
What I'll do is I'll monitor the patient, run some serial troponins, some serial EKGs. It's just part of the process of getting admitted to the hospital. They're not going home.
Right.
The problem is that we're delaying revascularization.
Right.
And so right now in the current paradigm in the emergency room, I will see a patient that's not a STEMI. I'll get them admitted. I'll get the cardiology consult. Some ER doctors write the admit orders. Some don't. Some have hospitalists that do all that work. But whatever. The point is, across the country, really globally, if it's not a STEMI, it's going to delay the revascularization of a blockage potentially.
Right.
What we're finding with the data is that there are a lot of false negatives. See, right now, it's really important we understand this, is that if you find a STEMI, it's going to go to the cath lab. And when it goes to the cath lab, it may not be a STEMI, actually. Oh, it's always a STEMI. It's always ST elevation pattern.
But there's no occlusion.
But what we're looking for isn't STEMIs.
Right.
That's a pattern. What we're looking for is occlusive lesions that are blocking blood flow to an area of the myocardium, because that myocardium will die without blood.
That's right.
And that's the goal. It's not STEMIs. That's a pattern.
Yes.
If you don't see a STEMI, all right, I'll just back up. If you do see a STEMI, it's going to go to the cath lab. If it goes to the cath lab and it was benign early repole or, angina or Prince-Middle's angina or maybe pericarditis or whatever, right? Or Takotsubo, we've talked about that before. They're going to have clean coronaries.
Yeah.
That would be a false positive.
Right.
It had ST elevation, looked like a STEMI, but it went to the cath lab, it was a false positive.
Right.
If it's not a STEMI, so EKG does not show STEMI,
Right.
you take it to the ER, you get your serial tropes, they get to the cath lab eventually, and it shows a fully occluded LAD or something like that, right? Or they also measure flow rates with this the TIMI flow rate, but basically, by definition, it's shown to be an occlusive lesion.
Right.
Those would then be a false negative.
Right.
Initially, we said it's not a STEMI or non-STEMI.
Right.
In our mind, we think not a heart attack.
Right.
Well, that's not true.
Yeah.
It just didn't have the STEMI pattern on it.
Right.
So the whole problem is called confirmation bias. When you're using the pattern to determine the index test, that's not right. Statistically, that's wrong, right?
Right.
So what we need to do is we need to open up the blinders a little bit to look for other patterns. And these 11 patterns that are outlined in this literature that came out this month shows a significant minority of patients, up to a third, maybe even more than a third.
Yeah, significant minority doesn't. Well, anytime you put minority, that sounds bad, but it's 34%. If you're in that 34% of patients, that's pretty important to you.
That's right. The majority of those occlusive lesions will be a STEMI pattern.
Right.
But a significant number, maybe is a better word to use, a significant number of patients, even more than a third of all occlusive lesions, will show up as a not a STEMI pattern, but something else.
Right.
So this whole idea of the possibility, and actually the data showing it now, is the false negatives that we're seeing in the hospital.
Right.
And the scary thing, again, just to back up, because this is getting complicated, right? The goal for us in the pre-hospital environment is to identify someone who could have an occlusive lesion.
Right.
That's the goal. Okay?
That's the goal.
That's the goal.
Yep.
Most of them will look like STEMIs.
Yeah.
But some don't look like them. So we have to open up our eyes to look for those other patterns.
So as a paramedic, I think that you need to keep in your head that you have your patient with chest pain or you suspect is having some sort of a cardiac event.
Right.
You run a 12 lead on them. Initially, you're going to look for that STEMI, that ST segment elevation. You don't see it. What we're saying is you're not done. That doesn't mean now that they're not having some sort of an occlusion going on. Mm-hmm. And so you need to take a deeper look. Yes, initially look for that ST elevation. But then if they're not having that, you need to look for these other signs. And the other thing I get guys get hung on is they feel like they have to memorize this stuff. It's like Scarbosa criteria when that first came out. Yeah. Like everybody's like, I can't, then don't memorize it. Like, I mean, I know Scarbosa because I've taught it for years. So after teaching it numerous times, I know it pretty well. But I get it. Like, if there's so much stuff that we have to know, like you don't need to memorize Scarbosa. Yeah. What you need to memorize is the indications to look for Scarbosa, right? Left bundle or a pacemaker. And then say, oh, they've got a pacemaker. Oh, Scarbosa criteria. Let me get out my chart that you should have in the back of the ambulance and let me look at what is Scarbosa and, reference that to my 12 lead. And, okay, are they having it? That's fine. Yep. That's perfectly fine. Or now we have AI that can do that. Yep. And these criteria are very complicated, and there's a lot of them.
Right.
And so I think the more, and we'll post a link to this article on there so people can reference this article and read it. It's a good article, and it has pictures, so it's very firefighter friendly.
And we are again we're filming our high risk cardiac course.
Right.
And that will be coming out soon too.
Where we'll go in depth of all the.
That's our next thing in the queue to film. Yes. So we're gonna, and that we'll go over these patterns.
Yes, in detail with all the stuff. Yeah, this is just kind of an overview of, like you said, it's the paradigm shift. For years, ever since I've been a paramedic, it's STEMIs. STEMIs is a heart attack. STEMIs means they're having an MI, whatever. And now they're saying, not always, right? Yes, look for your STEMIs. But now we're finding, the data is finding that there's these false negatives. Yes. These patients are sitting in the hospitals dying. Their cardiac muscle is dying because, and even physicians they're doing the same thing. So this is cutting edge stuff. And you guys can be on the cutting edge of this.
And every physician I've spoken to did not know some of these patterns. It's not just us in the pre-hospital environment. No. Nobody's behind. Everybody's behind. We're all stuck in a paradigm.
I printed this out this morning, and it had new stuff on it that we hadn't talked about yet. Right. So this is an evolving thing, and it's just something to have on your mind. Talk to your medical director about. This is changing. There's more data coming out.
And speaking of data, I think it's important for people to understand something. All of us to understand this. Physicians, paramedics, EMTs, all of us should understand that in the past, we did not send some of these patterns to the cath lab emergently because of the risk. Like there's a survival risk. You're taking a risk going into the cath lab.
Right.
By taking everybody with some of these patterns to the cath lab, they used to think that there was no survival benefit to it, so it was not an indication to emergently go to the cath lab.
Right.
But today what we have found is that some of these patterns have double the mortality risk.
Right.
And so they really do need to go emergently to the cath lab.
Right.
And if they don't, they have a high risk of dying. Now, I think we've got to tell the story, Brenda's story.
Mm-hmm. You tell it. You know it better than I do.
Well, you and I both know
the
nurse friend of ours. Yeah. And her 31-year-old son was working out at the gym. Well, let me back up a second. What's really cool about this is that we filmed the first OMI podcast.
That's right.
About 6 months ago?
Yeah, something like that. 8 months ago.
Yeah. And she had watched that, and she had was familiar with some of these lesions. Anyway, her son goes to the urgent care for some chest pain he was having while running at the gym. Got the EKG at urgent care, which we've posted, and it's clearly one of these signs.
Yes.
They didn't recognize it, sent him home.
Yeah. Because they were looking for STEMIs.
Right. And he was chest pain free.
Yeah.
Which is actually part of this pattern.
That's right. Yes.
And so Brenda saw the pattern. He went back to the ER, and the ER EKG showed the same pattern again. Brenda has literally texted me, "Thank you for the podcast. You saved my son's life."
that's worth doing.
They had
a podcast
tremendous
right there.
difficulty getting him admitted to the hospital, even at the ER, because the ER doctor recognized the sign that Brenda showed him, but the cardiologist did not.
Yes.
Well, no, I think he recognized
But
it.
he didn't believe in the, yeah.
Yeah. Well, he went to the cath lab that night, fully occluded widowmaker, the LAD.
Does the
100%.
cardiologist believe it now?
Probably.
Yeah, I
probably.
hope so.
And in the cardiologist's defense, they're looking at data that it may
Yes.
just be older, but
Yeah.
the new data shows that these patterns are highly suggestive of an occlusive MI,
Right.
and we need to be looking at them. And it's not just the pattern. We got to look at the patient. Got to evaluate your patient.
Right.
We know these patients that have an occluded MI, or sorry, the OMI, occlusive MI, they look gray.
Yeah.
We know they're sick, they're sweaty, they're sick, they're vomiting. You know,
Yeah.
right?
There's something going on here.
Right.
Yeah.
And then there's those patients that it's like, oh, they don't look good, but I've seen worse. But, and then you look at the EKG and it's like, whoa, this is one of those patterns.
Yeah.
These patterns could tip the scales for you and the care team, the
Yep.
cardiologist as well. So we need to be spot on with these.
There's, to back up, and this is more for the lay people.
Yeah.
If somebody's having chest pain, go to a hospital.
Yeah.
I just want to throw that in there. Like,
Yeah,
do
yeah,
not
yeah,
go to
yeah.
an urgent care if you are having signs and symptoms of a heart attack or a stroke or some major thing.
Yeah.
Don't go to an urgent care. Go to a hospital, preferably
Yeah.
a PCI capable.
Yeah, and it's
facility.
not just the left arm, right?
Yeah,
Radiating
right,
pain.
right.
It's actually both arms
Or no
right
arms.
arm.
I mean, it could be jaw.
Right.
Like, yes, I mean, we've talked. Yeah, the patient presentation is all over the map. I've had big, huge, tattooed guys that look like they just got out of prison, rolling
Right.
around, screaming and crying like a little girl, having heart attacks. And then I've had little 80-year-old ladies. I just don't feel right, having a huge MI.
Yeah, that's-
So there's no set pattern. Everybody's
Mm-hmm.
different.
I like how you went back to the layperson, because if someone is having an occlusive MI, it may be just weakness.
Yeah.
It may be jaw pain. It could be elbow pain. It could
Now, we're
be
not saying just because
vomiting,
your jaw's hurting, you're having a heart attack. That's not what we're saying. We're just,
but it could be.
But it could be. But yes, it's, yeah.
It's hard because
It's very hard.
it's the number one killer of people.
That's right.
18 million people die every year from cardiovascular disease.
Right.
And if you're feeling any form of chest pain, shortness of breath, weakness with radiating pain to your arms or your jaw, if you start sweating, in the context of these symptoms,
Yep.
you need to get to the ER as
Yeah,
quick
call
as you
911.
can. That's right. Call 911.
Yeah, because
Right.
we have the ability, we can check, run an EKG on you.
Yep.
Aspirin is a huge medication to give.
The
Probably
only thing we do
I was
that
gonna
really
say,
saves
yeah.
lives.
That's the most, not the nitro, not anything else. The
Well,
aspirin is.
And I think early recognition. You said that earlier.
Well, yes,
too. I
yeah.
mean, that's
but as far,
really
yeah,
what
the early, exactly. We
Yeah.
can. So I'll tell you one of the things that I've changed in my practice that I didn't used to do. I used to hate doing 12 leads in the house. I'm like, this is stupid. Why am I going to hook up all these wires on this patient just to get them up and unhook them all, just to get them on the cot and hook them back up again?
Yeah.
And I've changed the way that I do that now because I realize I can, especially if I'm up like in an apartment or in a nursing home. We have multiple nursing homes in my
Right.
city. I might be on the third floor. I might be a 5+ minute walk back to the ambulance. Well, when I go to those facilities, I will take the cell phone with me and run the 12 lead. And if I see, especially if it's late at night, if it's on a weekend, a holiday or something like that, and I know like there's no cath team at the hospital right now, I'll run that 12 lead. And if it comes out that they're having a STEMI or I see something like this, transmit and call them immediately because that starts their clock.
That's exactly right. And that's why the early recognition is so important.
Yes.
Is you start to mobilize the cath. It's not just the cardiologist. It's the whole
It's
cath
the-
lab
right,
team.
right.
It's clearing the cath lab.
Yep.
It's when they know something's coming, things happen
Move faster,
And
yeah.
that saves lives.
Yes,
Yeah.
100%. Yes, 100%. Yeah, we need to look at this. A friend of mine did a talk once about STEMIs or MIs, and it was bullets to the heart. And when we go on a sucking chest wound patient that's been shot in the chest, like we all kind of get our adrenaline up, and we're like, oh, this is. And then when we go on a STEMI patient, we're like, we kind of get excited, but not to that level.
Yep.
The end result's the same. The heart is going to die. It's going to stop beating. So
Yep.
these patients are going to die on you if you don't get them there quick.
That's right. And that's what happened with Brenda's son,
That's right.
31-year-old. And now Brenda's son, he has a son too.
Yeah.
And that son nearly lost his dad.
Yeah, it's
Brenda
huge.
nearly lost his son.
Yeah.
Because of a lack of recognition of a pattern that we should all know.
That's right.
I will say one more thing, and I agree with you. Going in and memorizing every tiny little detail of these things, I think is hard work, and I think, and it's sometimes maybe feels daunting. But
sure.
But again, I think we owe it to our patients to try do our best to learn all of these patterns.
Yeah.
Understanding though at the end, there are some great AI tools.
Yeah.
That can back you up.
Well, what was the data you said on the?
Yeah, it's crazy. I mean, the AI tool was, I think, 98.4% sensitive. I think there were a lot of false positives, but it didn't miss people.
Right.
Which is really the goal.
Right.
And then they were compared to a group of physicians, and they were at 80.4%. As far as being sensitive. So they didn't have as many false positives, but they were missing people with these patterns. So I think the good news is, and I think PM Cardio is one of the more well-known AI free EKG apps you can use. I tested it out on some of these lesions trying to trip it up, and I couldn't trip it up.
Really?
But I'll say this, though. Do not rely on these things. We need to know them. And you said it really well. Scarbosa, for example, is like knowing to look for the signs of scarbosa. You know, okay, I've got a left bundle branch block here. I've got a wide QRS. I'm going to pull out the reminder of those criteria because I recognize that it's a left bundle.
That's right.
And so then I can get the details on my hand, my app. And then I can use another app to even take a picture of it.
That's right.
Those are really smart things to do. It's almost like a checklist.
Yeah.
It's like in my mind, I've got a checklist of these 11 lesions here, and I can identify the South African flag sign.
That's right.
I can identify Wellens. I can identify De Winters, and I can identify, film Aslangers, all these new patterns, right? I can identify that potential. It's like, hey, you know what? I studied, and you say this better than anybody. What do you study when you're looking for counterfeit bills?
Oh, yeah, you study the real thing.
Study the real thing.
Normal sinus rhythm. Yeah.
That's exactly right. So if you study normal and you see something that's not normal, oh my gosh, there's something wrong here. That's when you pull these things out and you start, okay, you know what? This looks like South African flag sign. I'm going to pull this. Sure enough, ST elevation in 1, ST elevation in AVL and V2 with ST depression in lead 3. Yeah. Wow, I think I got one.
And then
this patient
transmit it.
It transmitted, and this patient looks sick.
Yes.
Yeah, that's right.
This one good thing about this article is, and like I said, I'll put a link in there, is that it has a great diagram, a breakdown of each one of these signs with pictures of what the leads, the changes look like.
Yep.
So that I'm going to take that personally and laminate it and put it in my protocol book on my ambulance.
Yep.
That way, if that happens, because again, it's just like I said with Scarbosa, it's going to be hard to memorize these, but once you start to use them, it'll take time. And if every time you do a 12 lead, you pull that out. Over time, it's going to get stuck in your brain, and you're going to have them memorized, if you're using them a lot. But again, reference that, send off your 12 lead and say, hey, doc, this is what I think's going on. Can you double check me?
Yep. And I love it that you said that because that's the danger is relying too much on technology.
That's right.
And I fall into the same bucket when I'm in the ER wanting to rely on a CT scan. There's nothing that can ever replace my hands on a patient's abdomen.
That's right.
Palpating. In fact, one of our colleagues recently, I was with him. I did the belly exam on our conference room table downstairs. I'm like, wow, this exam is impressive for an appendicitis. I took him to the ER. ER doctor hardly touched him and said, that's probably a gallbladder. And I'll get the ultrasound. I don't think we need to do a CT. I kind of looked at his exam, and I knew what my exam was, and I said, I think I'd examine him again, and I'd really want to have you consider getting a CT scan. I'm concerned about it, this being an appendicitis. And sure enough, we knew it, and from the beginning, it wasn't a gallbladder, it was appendicitis. He went to the operating room for an appendicitis. My point for that is, the CT scans are great; they're confirmatory studies, but you've got to be good with your own assessment.
Yeah.
Your own recognition of this not being a normal EKG, and then identifying the potential pattern, transmitting it, communicating your concerns, and getting them to the right hospital at the right amount of time.
It's a good way to end it. See you in the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.